Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. Today we are discussing an essential topic for primary care practice, which is seborrheic dermatitis. This common chronic condition may not be life-threatening, but it certainly impacts quality of life. Today we'll dive into its clinical presentation, diagnostic features, management, and the all-important patient education. Let's get started. Starting off with some basic pathophysiology, seborrheic dermatitis is a chronic inflammatory skin condition that occurs in regions where sebaceous glands are most active, like the scalp, face, and upper trunk. The cause of seborrheic dermatitis is not fully understood, but is thought to be due to Malassezia furfur and an abnormal immune response. Some patients are worse during the winter in a dry indoor environment. In addition, interestingly, sunlight exposure causes seborrheic dermatitis to flare in some patients, while promotes improvement of the condition in others. Who does seborrheic dermatitis affect? This condition spares no age group. It's common in infants, where it's known as cradle cap, and peaks again in adults, most commonly between 20 and 50 years of age, particularly men. And it's important to know that there is an increase in incidence with neurologic disorders such as Parkinson's and in immunosuppression. The clinical presentation of seborrheic dermatitis is erythematous papules or patches with waxy, greasy, yellowish scales. In adults, the scalp is often involved, leading to dandruff. You might also see lesions in the nasolabial folds, eyebrows, and retroauricular areas. Seborrheic dermatitis may also present in the diaper area in infants, where it may mimic other conditions like diaper candidiasis. In these cases, history and distribution help differentiate. Diagnosis is typically clinical. Look for characteristic lesions in classic locations. If there's diagnostic uncertainty, a KOH prep can help rule out dermatophytes or candida. But usually, seborrheic dermatitis is a slam dunk diagnosis based on appearance. Now, let's talk about management. For the scalp, start with over-the-counter shampoos such as ketoconazole, selenium sulfide, or zinc pyrithione. For more severe cases, topical corticosteroids can be added on. For other regions, including the face, topical antifungal creams like ketoconazole as monotherapy or combined with a topical corticosteroid can be used. But always remember to educate patients on the risks of prolonged steroid use, especially when used on the face or intertriginous areas. And for infants with cradle cap, typically you start with conservative measures, with application of an emollient like mineral oil, baby oil, or olive oil. You can leave the emollient on overnight if necessary, and then remove the scales with a soft brush. This is followed by frequent shampooing. And then, don't forget, this is a chronic condition. You will want to educate on the intermittent use of something like ketoconazole shampoo or cream weekly for maintenance therapy to prevent relapse. Speaking of prevention, for those prone to flares, you want to also educate on stress management, since this can worsen seborrheic dermatitis. Here are a couple of clinical pearls. Number 1. Seborrheic dermatitis often coexists with other conditions like rosacea. You may want to consider this when treatment isn't working. And number 2. Remember that lesions in the diaper area of infants can mimic candidiasis. A good history and close examination are key. All right, let's do some practice questions. Question 1. A 35-year-old man presents with a 2-week history of an itchy, flaky scalp that is also affecting his eyebrows. He's tried switching shampoos, but the flakes persist. Exam reveals erythematous plaques with greasy, yellowish scales to the scalp and eyebrows. No signs of infection are noted. What is the next best step in management? Is it A, oral antifungal therapy, B, ketoconazole shampoo, C, oral corticosteroids, or D, topical calcineurin inhibitors? I'll give you a couple of seconds. If you chose B, ketoconazole shampoo, you are correct. This presentation is classic for seborrheic dermatitis. Initial treatment involves antifungal shampoos like ketoconazole, selenium sulfide, or zinc pyrithione. Question 2. A 4-month-old infant presents with a rash to the scalp. The infant is otherwise healthy and feeding well. Exam reveals yellowish greasy scales on the scalp. No oozing or pustules are noted. Which of the following is the best initial treatment? Is it A, topical clotrimazole, B, topical corticosteroids, C, observation and gentle scalp care with mineral oil, or D, oral antifungal therapy? If you chose C, observation and gentle scalp care with mineral oil, you are correct. This is classic cradle cap, a self-limiting form of seborrheic dermatitis. Gentle scalp care with emollients and regular shampooing usually resolves the condition. Great job! Thank you for tuning in to this episode of the Pro PA podcast. Seborrheic dermatitis may not be the most severe dermatologic condition, but it's one you'll see frequently in primary care. Knowing how to identify and manage it effectively can make a big difference for your patients. Don't forget to subscribe and turn on notifications so you never miss an episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.